So I will discuss very briefly, because we're running out of time, a couple of concepts that has been already mentioned here. The first one that is critical is that unlike most solid tumors, and you know that, HCC arises in a previously damaged organ. This has remarkable impacts when you're talking about treatment during the patient, prognosis prediction, because there are two components that can eventually kill the patient. And even though it has mentioned there are significant changes in how we treat viral hepatitis, particularly hepatitis C, with new agents coming probably at the end of this year, high rates of sustained virological response, and probably interferon-free regimes in the very near future, there is a huge amount of patients with NAS-related HCC in the US and United Kingdom that are coming, and it will be a huge bulk of patients in the next years. There's a recent epidemiological study published in Lancet that analyzes outcomes in the United Kingdom, death due to different causes, infectious, non-infections, tumoral, non-tumoral, etc. And it's remarkable that liver diseases pop out as one of the major killers in the last 20 years. And according to one of the statements in that review, that study, said that as identified by the Chief Medical Officer for England, the prevalence of various forms of liver disease has increased substantially in the last 20 years. That means that we'll have more liver cancer in the next years. So this is the BCLC algorithm. You've heard about this. We're talking about systemic therapies and novel agents. They're not much novel to say. What you know is that sorafenib is indicated in patients with advanced HCC, meaning that patients, the disease is outside the liver, either with vascular invasion or extrahepatic spread, and also for patients that were treated, they were intermediate state, treated with TACE, and progressed after the treatment. This is the current guidelines according to the EASL ERTC. And where the data from sorafenib comes, I'm sure you know all that, familiar with this study. There was a first two study, I would say largely large study performed on unresected HCC, 30% of patients child B. There were not many partial response, and when we look at, they analyzed biomarkers of response, they found that phosphorylated ERK could be a predictor of response. And the conclusion of the authors at this point is that although the single agent sorafenib didn't have much toxicity and so modest efficacy, it could eventually have a room as a combination therapy. As it turned out, sorafenib by itself was effective, was able to increase survival in patients with advanced HCC, as was shown by the SHARP trial, the registration trial for this compound. These data were later validated in the Asian Pacific study that you're familiar with, making sorafenib standard of care for patients with advanced HCC. But how sorafenib works, and I challenge anybody to say precisely which is the mechanism of action of sorafenib, because we honestly are not sure of how it works. It's a multi-tyrosine kinase inhibitor, blocks PDGFR, VEGFR, BRAF, among other kinases. It is anti-angiogenic. But again, we don't know exactly how it works. We know it's effective, but the molecular mechanism behind it could be a combination of them. We don't know exactly which is this mechanism. In fact, the biomarker analysis conducted in the SHARP trial, this is analysis based on serum biomarkers, found some possible associations, but the bottom line is that none of the plasma biomarkers tested significantly predicted response to sorafenib. So again, we don't have a particular population of patients with advanced HCC that could maximize their response to sorafenib. So this was 2007. Sorafenib, the trial was early stopped due to positive effects. It was approved. You have here the drug, you have here the expected targets. Then people went crazy because there was a huge opportunity to treat HCC with systemic, and particularly molecular target therapy. So all the companies start performing trials, large phase 3 trials. You have sunitinib trial that among other, let's say, kinases that were already blocked by sorafenib, you have an additional one like c-KIT, you had lenifenib, first line erlotinib, also Brivanib in first line, but you also have second line options, everolimus, ramucirumab, and tivantinib. These are all phase 3 trials, so potentially registration trial. And the status as per today is that the sunitinib trial was negative, lenifenib was negative, erlotinib was negative, and Brivanib was negative, the second line and the first line. So the approach followed so far, I would say, hasn't been very successful in terms of trying to parallel or even improve results of sorafenib in first line or in second line. But let's dig a little bit in the specific analysis of some of these trials. They're not published, to my knowledge, even though some of them were reported a couple of years ago. Significant publication bias in this sense. Sunitinib versus sorafenib, a well-designed trial, very similar to the SHARP, BCLC-C patients, more than 1,000 included, stratified, primary endpoint, overall survival. Data Safety Monitoring Committee stopped the trial prematurely due to toxicity and futility. As you can see, sunitinib was doing significantly worse than patients with sorafenib. And this was already suggested in the phase 2 trials, but despite that, the large phase 3 was run. And this is remarkable because sunitinib is approved and it's been used in other malignancies. So there is something about HCC and probably its underlying liver cirrhosis that limits the applications that other patients without this disease could eventually receive. Another example in second line. There is some molecular evidence, and I would say repeated and robust data that suggests that a number of patients, around 11–10%, have high-level amplification of a region of the genome that is chromosome 11q13. This amplicon has different genes, and one of them is FGF19. There is experimental evidence that suggests that in experimental models of HCC, both in vitro and in vivo, when you block FGF signaling, you have antitumoral responses in experimental models. So there is all of the rationale that you can find to test FGFR inhibition in hepatocellular carcinoma, and this was tested in second line and in first line. These are the results of the second line. Again, it's a very well-designed trial, randomization 2:1, more than almost 400 patients, stratified, primary endpoint, overall survival in patients that progressed or were intolerant to sorafenib. Primary endpoint, trial was negative. So Brivanib, an FGFR inhibitor, was unable to improve survival compared to placebo. However, you have some readouts that Brivanib was being active in terms of time to progression and response, meaning that it could happen, and this is again a speculation, subgroup of patients, those that specifically has activation of the pathway, could benefit from this treatment. But since we treat them all, the treatment could be diluted. And I insist, it's just a speculation, but could partially or maybe justify this. So the bottom line is that we need new approaches or new pathways. As I mentioned, there are additional pathways being tested currently, like the mTOR inhibition in second line. The combination mTOR-sorafenib was a little bit toxic, so it was not pushed forward, but everolimus is an mTOR inhibitor being tested in second line. We work on preclinical data that show that this pathway is activated in a number of patients. I think we have to also test novel, different approaches in the standard tyrosine kinase inhibition. We've worked on notch signaling. It's a very interesting pathway in terms of differentiation in the liver. We show, using animal models, that overexpression of notch induces liver tumors in mice, transgenic mice, that are very similar histologically to the human tumors. And using comparative functional genomics, we were able to train a signature that predicted response to notch inhibition in experimental models of HCC. Another approach would be to target epigenetics, and there are two major, let's say, hallmarks of epigenetics here that you know it's DNA methylation and histone deacetylation. The Eptromic consortium that is led by Dr. Lovett in Barcelona is a FP7 grant that evaluated methylation profiling in a large set of HCCs, 221, using whole genome methylation profile platform. And we see that there are different HCC based on their methylation pattern. Moreover, you can select a set of markers of methylation, DNA methylation markers that are significantly and strongly correlated with patient prognosis. There are also preclinical data using HDAC inhibition. There are some HDAC inhibitors, HDAC, that are deregulated in HCC in human samples. When you do experiments blocking or inhibiting HDAC with panovinostat, for example, you get, again, antitumoral efficacy and effects in experimental models. But again, we need to look for new targets, and there's been, in the last 2 years, a number of approaches using next-generation sequencing that you all know is currently this hallmark for dense scrutiny of the human genome. This is a paper published 2 years ago in Nature Genetics, last year by the group of Jessica Thurman-Grossi. They analyzed 25 exomes, validated in 125. Most prevalent mutations in HCC are beta-catenin and p53. We already knew that. They are mutually exclusive, and they're not druggable at this moment. And there is a tail of low-frequency mutations, less than 10%, that affects a number of genes. I will not go into details. Some are related with chromatin remodeling. That is a very interesting point. This paper is published 2 weeks ago. It's the largest publication so far in exome sequencing in HCC. 87 exomes from the group of Derek Chan in North Carolina and Chapel Hill. They validated the results from the study of Jessica Thurman-Grossi. Most frequent mutations, beta-catenin, p53, and again, a small tail of I would say low-frequency mutations in the rest of the tumors. So again, in terms of DNA mutations, we have, say, robust data that beta-catenin is implied with. They're not drugs, I would say, in late phase that we can use for that, and p53, you already know that it's very difficult to tackle. Even though we're confident, we're positive, because there are a lot of data from molecular study that HCC is different, and this has been mentioned already. There are different HCCs. Their molecular classification enables us to identify different groups. And despite that you can have patients with tumors at the same clinical stage, they're molecularly different. That's why in the figure here they have different colors. Ideally, we will be able to classify them, as happened in other tumors, according to the molecular background or their oncogene addiction loops, identify mutations that could be targetable, or high-level amplifications that could be susceptible tumors to specific therapies, or overexpression of a given gene. This has been done with the Brivanib study that was already mentioned. I will not mention again. There is one limitation, and this has been shown in renal cancer in a very elegant study published in New England last year. It has been shown in breast cancer also. There is significant intra-tumor heterogeneity at the mutation level. We still don't know which is the impact of that. We cannot assess which is the, let's say, how many of these are drivers or passengers, if it's as functionally relevant. So there's still a lot of questions to answer. But this has to be considered in the algorithm, because it's not conceivable to do 25 biopsies of a patient of a tumor to see if it has 25 different mutations. This has been very, I would say, poorly investigated in HCC so far. So this is my last slide. As I mentioned, there are not many novel therapies. Most of them have failed in phase 3. I leave you with 3 challenges for the future in terms of translational research for HCC. We need, at least we need to try to find oncogene addiction as in other tumors. Low frequency, you can criticize that, but they have an impact in patient survival. They will improve sorafenib results in first line, enable to find biomarkers of response, deployment of trial enrichment strategies. We need to map heterogeneity and have or obtain non-invasive readouts of tumor complexity, either through tumor circulating cells, circulating DNA, mutated DNA, functional imaging, that is very interesting. And finally, have an idea of what are tumor dynamics. We have the lag to know the natural history of HCC. So most of the patients have underlying cirrhosis, so we have a long time to, let's say, analyze what are the mechanisms, the gatekeepers that transform cells, malignant cells in cirrhotic livers, into HCC. And finally, I would like to thank, because I've presented data we generated while I was working at Sinai and also in Barcelona, and I thank you very much for your attention.